Hi and welcome to CD3 of our basic FESS guide. In this CD we'll be talking to you about the pre-op preparation through to the actual surgical steps from uncinectomy to ethmoidectomy. So let's start with the pre-op preparation. We have already discussed in some detail about the informed consent and why it is important. Medical treatment has also been discussed in CD2 as well as the radiology. All our patients are assessed for GA fitness. Even in a limited FESS situation, such as the one you can see on your scan here, where it's just a maxillar involvement, we will still have the patient fit for GA because you never know when a patient may become uncooperative or what kind of medical problems the patient may have because you haven't got his blood test or his full evaluation done. You also have to make sure that he is not on any aspirin or any other anticoagulant or blood thinning agent. Nowadays, a lot of patients are on these medications, and it is important to make sure that he is not taking any combination pills or drugs which the patient themselves may sometimes be unaware of that may cause to excessive bleeding during surgery. At the end, once your patient is fully fit for surgery, it's equally important that the surgeon must also be ready for the surgery, which means he should have understood the patient's problems, the pathology, the need for the surgery, the amount of surgery required, and properly assessed and evaluated the entire set of CT scans so that in his head he has a full mental picture of the patient's anatomy, architecture, pathology, as well as how much of surgery he needs to do and a full surgical plan as to how the surgery should progress. Coming to the actual steps of surgery, unless contraindicated, most of our surgery is done under general anesthesia, and this is because again a vast majority of our patients do have posterior ethmoid or sphenoid disease, and in very few patients will there be very limited just anterior ethmoid disease or just a little bit of osteomeatal complex disease, and we feel that most of these patients are amenable to medical treatment and therefore usually do not require surgery. However, there will be some situations like an antecoronal polyp or small isolated cysts or polyps that could be done under local anesthesia. The patient is kept in a supine position with head elevation and the head slightly rotated so as to face the surgeon. Local preparation consists of decongestant nose drops, and these will be put into the patient's nose just before the patient is wheeled into the operation theatre, so that when he comes into the theatre, his nose is now completely decongested. And what this does is it makes your packing with xylocaine adrenaline much easier because now you have a nice wide open nostril. It's less traumatic and more comfortable for you to get into the smaller recesses of the nose and therefore do a better packing. Usually we do not inject as a routine. In my setup, I do not inject the patient usually unless there is some indication. There is a vascular pathology or there is some specific indication. In a standard basic FESS surgery, we generally tend not to inject at all. Right, so coming to the nasal preparation itself, this is how we would pack the nose. We use cottonoids or nasal patties which are dipped in xylocaine with 4% xylocaine with adrenaline. We use a relatively high concentration of adrenaline, about 3 ampules in 30 ml of xylocaine with the consent of the anesthetist, and only of course for surface anesthesia. These patties are squeeze dried so as not to have excessive adrenaline in them. Once the patties are introduced in the nose, you use a Freer's elevator to gently manipulate these patties into the middle meatus. This whole process should be as less traumatic as possible. Try to be very gentle, try and just ease the patty into the middle meatus between the middle turbinate and the lateral wall, and then you see you have a nice decongestion of the middle meatus and you have relatively no trauma or bleeding that will interfere with your surgery later. Coming to the steps of surgery, we could start with an uncinectomy, and this is the way that we normally approach our FESS patients. We would first, as a first step, do an uncinectomy, follow it up by a maxillary sinus ostium widening. Then we would approach the frontal sinus using an intact bulla technique, following which we would do an ethmoidectomy. There will be situations where we are unable to find the frontal sinus ostium, and we will not waste too much time in then trying to find it. In those situations where we have trouble finding the frontal sinus, we then proceed to doing an anti-ethmoidectomy, and then it makes the use of an angled endoscope a lot easier. So we would go back to the frontal sinus and then maybe sometimes even finish the posterior ethmoidectomy and go back to the frontal sinus. So there has to be some amount of flexibility in your surgical plan. And finally, after the ethmoidectomy, we would end up with doing sphenoid sinus surgery. So when we start the uncinectomy, there are various ways to do an uncinectomy, and maybe 10-15 different ways of doing uncinectomy. The steps of surgery that we described in this CD are the ones that we follow as a routine in our institute, and these are the ones that we will stick with. So we would tend to use either an elevator, which is a Freer's elevator, or a backbiter, be it a Toby's, a small Toby's backbiter, or a regular ostrom, or a debrider. What is important is that the uncinectomy should be from the attachment, the anterior attachment near the anterior edge of the middle turbinate, all the way down to the inferior turbinate. This complete removal, especially in the inferior horizontal part, is important if you want to make identification of the ostium easy. If you do not remove the inferior part, you will always struggle to find the maxillary sinus ostium. Of course, removal of the upper part will facilitate dissection towards the frontal recess, and the middle part makes your ethmoidectomy easier. We have found that this very simple step, often not done well, often results in one of the commonest causes for your surgical failure. So we're going to show you how we do an uncinectomy. One of the ways, we're using a Freer's elevator. This is the middle turbinate, we're on the left side, ethmoid bulla, marking the anterior attachment of the uncinate to the frontal process of the maxilla, and right from the axilla superiorly all the way down to the upper part of the attachment of the inferior turbinate, you must take an incision that goes through the mucosa and through the bone. Once that is done, we can then use an ethmoid forceps, and with a gentle rotatory motion away from the turbinate, so as not to strip the mucosa of the turbinate. So when you go superiorly, we then rotate the forceps in the opposite direction away from, as you can see, the turbinate, and then the entire uncinate can come out in one piece. The way we do the uncinectomy now is really a hybrid between using a backbiter and the elevator. So we take the vertical incision with a Freer's elevator, and we prefer this to a sickle knife simply because it being blunt is less likely to cause trauma to the orbit in those cases where you have a lateralized uncinate. So the vertical incision having been completed, we then switch to, in this case, a Toby's backbiter, and coming from the infundibulum anteriorly, cutting away the inferior part of the uncinate at its horizontal inferior attachment. And having done that, detach the uncinate inferiorly and anteriorly, we can then remove the uncinate in an intact piece, and that will immediately expose the ostium of the maxillary sinus. Having completed the uncinectomy, we can then turn our attention to the next step of the surgery, which is then the maxillary sinus. So once this door has been removed, our approach or vision of the other sinuses is much better. For the maxillary sinus, there are a couple of important points. One, as we mentioned earlier, the uncinate must be removed completely, especially in the inferior part. Occasionally, despite this, there's a lot of edema, swelling, mucus, granulation sometimes that hide the ostium. and then you need to do a probing over the inferior turbinate, starting more or less at the center part, just under and anterior to the ethmoid bulla, and watch for air bubbles. And where you see bubbles is where you're going to be looking at probing to find the ostium. In the earlier days, we used to widen anteriorly because we thought that was safer, there was less chance of bleeding. But if you do that, you must stop when you hit bone, which means where the uncinate ends. Because if you go anterior to this, you're going to hit the harder bone process of the maxilla and potentially not only damage your instrument, but also cause damage to the nasolacrimal duct. If we go posteriorly, and which is what we do nowadays, then you can join it with the posterior fontanelle to have a nice wide ostium, which makes it easier to visualize even in the post-op phase. The only problem is occasionally you'll hit branches of the sphenopalatine, which you need to deal with. When you're working within the maxillary sinus, remember you will need to use angled telescopes and curved instruments, especially if you want to get to the inferior and anterior parts or the more distant parts of the sinus away from the ostium. So just an example of how sometimes there's a lot of edema, you need to probe and you can see the pus coming out so as to stimulate air bubbles, and you would know that that's where the sinus ostium would have been. Having removed the uncinate, just to show you a series of photos, and you would see how the maxillary sinus was immediately identified on completely removing the uncinate. In this situation, you see the maxillary normal ostium in front and an accessory ostium at the back. And what this commonly does is, even though you have apparently a large ostium, you have a recirculation of mucus. So mucus comes out of the ostium, goes back through the accessory ostium into the maxilla, and then again with a mucociliary flow out of the normal ostium and into the accessory ostium. So you have a recirculation of mucus that happens all the time, leading to persistent chronic maxillary sinusitis. So what we have to do is to join these two openings and make it into one common opening, so that drainage then occurs into the common drainage pathway into the nodes. So in this situation, we're using a backbiter. We're into the posterior fontanelle. You can see the open jaw. Taking a bite of the bridge between the two, you can see it being slowly removed, and the inferior part is being removed. We'll also remove then the superior part, and then it's easy to suck away all the mucus within the maxillary sinus and have a nice wide open drainage into the nose. So we're going to show you a clip where we had an isolated maxillary cyst, no other problems, and in that case we can do what is called a limited FESS. So we'll do only an inferior uncinectomy. So using a backbiter again and coming about 1/3 to 2/3 way up, just above where the uncinate turns inferiorly and becomes horizontal. We will incise that part using our backbiter, and already with the first two bites you can see a little edge of the maxillary ostium there coming into view. Then you can remove the inferior part of the bone, remaining bone of the uncinate process, and you can dissect the mucosa away from the bone and remove the bone separately, and then use a debrider to take away all the excess mucosa. So that's the remaining bone of the uncinate above the inferior turbinate that's coming out, and you can already see the cyst in the maxillary sinus. We then extend our ostium posteriorly to join it with the fontanelle, and using a debrider then remove all the excess mucosa. In this case, we now have a nice wide ostium. You can see the cyst very clearly in the maxillary sinus. We also want to remove the excess mucosa inferiorly, and now we have a nice wide opening into the sinus. Once this little bit of the mucosa is inside of the cyst, you can see some fluid. It's a cystic polyp, so you can see the cystic fluid coming out, and in a way it's good for the cyst to decompress a little bit so as to make it easier to hold the wall. Here we're using what is called a Howitzer forceps to angle our way into the maxillary sinus and gradually pull the maxillary cyst, bringing it outward and pushing it gradually posteriorly, so as try not to detach it, try not to break it, and gently every time removing a little bit, then again reintroducing the hovisor inside the maxillary sinus and trying to get little more of the base. We can then, as you can see, remove the entire wall of the now decompressed maxillary cyst, so as you have then a nice clear maxillary sinus. And using an angled telescope, you can then look into the sinus and see that the entire cyst that was filling it has been removed even from the base. There may be times when it's difficult to get to the base. You can see the infraorbital nerve as well. Then you may have to combine this procedure by doing an inferior antrostomy or a small opening in the canine fossa. So coming from the maxillary sinus now to the frontal sinus, which to me is probably the most difficult part of the surgery, or for most people, because the frontal sinus, the drainage pathway is very narrow. On one side you have the orbit, on the other side you have the cribriform plate, and you have to work between these two important structures to try and find the ostium, at the same time preserve mucosa and have less blood or less trauma in your field. Important pointers for the frontal sinus are, remember your ostium is superiorly and anteriorly, behind which will lie the recess, behind which will lie the, or under which will lie the anterior ethmoid artery. You also have to remember that the supraorbital cell may sometimes be present in an inferolateral situation to the frontal ostium. We would start off using an intact bulla technique because almost always the frontal recess is anterior to the bulla. Occasionally, if you have a very large bulla or a very posterior recess, then you may have to remove part of the bulla to get access to the frontal recess. But usually intact bulla technique is a good initial step towards finding the ostium. Wormer's technique of building blocks, having a 3D reconstruction using all your 3 axes of CT scans to actually reconstruct your cells as they would appear and go cell by cell, more from an anterior to posterior direction, starting from your agar cell towards your frontal cells and then make your way into the ostium, also works very well in conjunction with the intact bulla technique. If at any stage we are finding difficulty or the bulla comes in a way, we will not hesitate to remove the bulla and the suprabullar cells to then enable us to use giraffe forceps, malleable instruments, curved instruments, and 45 or even a 70-degree endoscope to then visualize the frontal sinus ostium. In revision surgery, it is probably important or useful to use navigation-aided surgery, in which case it is then far more easier to do this frontal sinus surgery. There is now some thought to using balloon sinoplasty, and I think the initial results have been encouraging, but it is probably useful in only a limited limited indications, and in most situations you probably have to still stick with general surgery. And finally, remember, it is extremely important to save mucosa, not to have raw edges, because the incidence of iatrogenic frontal sinusitis is high in hands that are not gentle. So you do not want to start off surgery on a patient with no frontal sinusitis, be adventurous, give a lot of trauma, have mucosa damage, and then have the patient complaining of frontal sinusitis in the post-op period and make revision surgery extremely difficult. So when starting frontal sinus surgery, we would initially tackle the agar cells, then make our way to the frontal cells and find the frontal drainage pathway. You know from your scans whether it is medial or lateral, and you approach it with your plan in mind, whether you want to go for the lateral cells or the medial cells, depending on the anatomy, and find the drainage pathway and follow it up into the frontal sinus. Occasionally there will be cells in which the eggshell, as described by Stamberger, cover the opening of the frontal sinus, and you need to remove these eggshells, or what he called uncapping the egg, before you can have access into the frontal sinus. Once you have the ostium, you then need to widen it, and you need to widen it again being very gently to remove bone without having too much mucosa damage. You should also know the direction in which to widen it so as not to endanger the cribriform plate. You must learn to use angle telescopes and specialized instruments so that you can do all these things by saving the mucosa as much as possible. So what we're going to do now is to take you through a frontal sinus surgery, and the scans are similar to the same in fact to the ones that we saw in CD2, but to refresh your memory, I'll go through it again. We're going to be operating on the right frontal sinus. We're only going to talk of the right frontal sinus scans. So this is the front. We're looking at coronal scans here. Frontal sinus with a large medial cell. Second cut shows the frontal sinus with now two cells. There are one lateral cell and one medial cell. The type 3 frontal cell here. And below that, when we go, you see the end of the medial cell as well as the extension of the lateral cell and the small bit of the frontal sinus above it. And you would immediately realize from this that there doesn't seem to be any obvious drainage pathway, and it's very likely that we need to go through the roof of one of these cells to then enter into the frontal sinus. If you were to follow these cells lower down, we see that the medial cell is here and the lateral cell is now coming into the frontal recess in this area. The next scan shows us the agar nasa here in conjunction with the lateral cell. The medial cell has almost come to an end here, and that's the last bit of the frontal recess. So we need to get the agar cell out, identify the lateral cell, follow it up, find the medial cell, follow it up, identify the roofs of both the cells, and then go through the roof into the frontal sinus. If we look at the axial cut again on the right side, we see that there has the agar cell, the lateral cell and the medial cell and the frontal sinus above it. Looking at the sagittal section, we know that type 3 cell, so we need to go quite high up and then go through, and you see it's almost touching the skull base here, so we need to go through the roof of this cell to enter into the frontal sinus. So here we've already done an uncinectomy. We're on the right side, middle turbinate is here, orbit is going to be here, and we have just opened into the agar nasi cell. This is the ethmoid bulla and the maxillary sinus which has been opened inferiorly. So, having found the agar, and we know this is going to continue into the lateral cell, I am now searching for the medial cell. So I am going to stay close to the middle turbinate and try and probe my way into this part and get that partition of bone between the two cells out. So at this moment we are somewhere here trying to find this partition of bone and take it out and then make my way upwards into this cell. So you see now a frontal seeker that's probing, and you can see how it's entered into that medial frontal cell and the partition of bone between the two cells, and that's the partition of bone that we need to remove between these two cells so as to be able to see better. We can now look right up into that medial cell, so we are looking somewhere up here. You can see the lateral cell as well, which is right here, and we can see the roofs of both the cells and the septal partition between these two cells, which is here. Now from our assessment of the scans, we know that unless we go through one of these cells, we don't have another obvious path of drainage to follow. So having removed the septum now between these two cells and identified this type 3 cell going way up and the lateral cell there, we are now ready to make our way into the frontal sinus by opening up the roof of one of these cells. So with using what is called a upward Stamberger mushroom punch, I then take a punch through the roof of that cell, the medial cell, so somewhere out here or in this area, and through that opening we can now look up and see into the frontal sinus. This is the roof of the lateral cell, which is at a lower level, and this is the cell in the medial part at the upper level. Having then exposed the frontal, I still have a little bit of the septum between these two cells to clear, so as to have my frontal sinus as wide as possible and have good drainage in the future. You see proof of having opened the frontal sinus by the fact that we got mucus, retained mucus from the frontal sinus, which is sucked out. We give a nice good saline wash to ensure that there is no secretions or mucus that remains behind in there. So that's the last bit of the mucus that's coming out. And then we can look inside and see very clearly the frontal sinus through the roof of these cells. So we have this area of bone here which we can clear or open up, remove, so as to have a wider frontal sinus. And gradually, using, in this case, a malleable probe, you can see I'm fracturing the septum, which will in this case correspond to this part. And using a Stamberger mushroom punch, again I punch out this bone so as to have a nice clean removal and yet have intact mucosa. I now have a much wider frontal sinus. You can see the frontal lobe here, and you have a nice widened frontal sinus. You see a little bit of the lateral cell here and completely marsupialized medial cell. So this is now a very good opening and should not be giving you any problem. We also have, as you can see, a lot of intact mucosa in the whole area, and we should be fine. There is, to end the surgery, still a little bit of bone between these two, that last bit of bone here, and we can now use a giraffe forceps, and you must have both vertical and horizontally opening giraffe forceps so as to have precise removal without trauma of whatever structures or bone pieces that you want to remove, and leave the mucosa intact. So that's the last bit of that bony septum coming out, and you can see now that you have a nice wide frontal sinus. Removed most of the bony septum, a small piece is there which will also be removed, and then you have completed your job of doing a frontal sinus surgery. So here we are using the Stamberger mushroom punch to remove that small piece of bone, and this instrument is really useful because you can use any of the circumference, any edge of the circumference, be it superiorly, inferiorly, medially or laterally, to remove the last pieces of bone. Having done that, you can now look right into the frontal sinus, and you'll appreciate how this looks quite different from that initial look that you had in the frontal cell, even though it looked quite far up and quite deep. And the bulla is still intact during this whole surgery. So we then would go in and open up the bulla, and this removal of the bulla would enable us then to visualize the frontal with even a 70-degree scope, which in this case might be a little more difficult having the bulla intact. So having perforated the anterior wall of the ethmoid bulla, we can then grasp with the straight ethmoid forceps and remove the upper part of the ethmoid bulla, and then have access posteriorly to the ground lamella and remove whatever little bits of mucosa that you want to with a debrider, excess mucosa with a debrider, being careful not to cause any damage. So now you can see the frontal sinus ostium, you can see the frontal recess which was partially hidden by the large ethmoid bulla, and the anterior ethmoid artery below it, which is here. And now you'll appreciate that it's a lot easier for me to use that giraffe forceps to remove that last bit of septum, which initially was proving to be a little difficult because the bulla was in my way. And this is the way that we would tend to work with the frontal sinus, that identify the frontal ostium, and then if you're having difficulty in widening it or seeing it better, take off the upper part of the ethmoid bulla and then allow us to use malleable instruments, giraffe instruments, 70-degree scopes. All these instruments far easier because you have that extra space inferiorly so that we can see. You can also confirm that you are in the frontal sinus by doing the trans illumination and seeing the light over the forehead, and that will tell you for sure that yes, you're in the frontal and nowhere else. So once again, that's the frontal recess and the anterior ethmoid artery coming into view a lot better once the bulla and the supraorbital cells are cleared. We then proceed, you already seen how the bulla is opened and removed. We then proceed now into the actual discussion of the anterior ethmoidectomy. The bulla ethmoidalis is your main anterior ethmoid cell, and the ethmoidectomy necessarily starts with removing the bulla ethmoidalis and approaching the sinus lateralis, which was a term used in the earlier days. Now we of course say the suprabullar region and the retrobullar region. So whatever cells are there present in these areas, and sometimes even in the infrabullar area, now need to be removed to complete an anterior ethmoidectomy. And the way to do it is gently to use suction and through cutting forceps or straight ethmoid forceps and debriders. The dissection should be gentle. At the end of your anterior ethmoidectomy, you should have the lamina papyraceae laterally, the fovea ethmoidalis superiorly, the ground lamella posteriorly, and the middle turbinate medially. When you're working on the lamina papyraceae area, use the sides of forceps. Never point your forceps laterally so as to cause damage to the orbit. Also, don't point your forceps towards the lateral cribriform. Remember that this area is 1/10 of the thickness of the fovea, and you could damage it without much effort. Another very important landmark is your anterior ethmoid artery. Try and identify it, because you know anterior to that is going to come your frontal recess and your frontal ostium, and that's very useful, especially in those cases where you're having difficulty in finding the frontal sinus. So to take you through now a video of the anterior ethmoidectomy. This is the ethmoid bulla. We are on the left side, middle turbinate, orbit laterally, and having punctured, an opening into the anterior part of the ethmoid bulla, we can then grasp the inferior part of the bulla, detach it, grasp the superior part of the bulla, and then the entire bulla almost comes out, as it were, in almost one piece. You see a lot of polypoidal mucosa as well attached to the bulla, and you can remove this whole thing as one large piece. Once the ethmoid bulla is removed, laterally is the lamina papyraceae. Unless there are retrobullar cells, posteriorly will come the ground lamella. You can see how the middle turbinate curves laterally and attaches now to the lamina papyraceae to form the ground lamella. In many situations, you will have suprabullar and infrabullar cells, and you need to remove them one by one, starting from inferiorly, going gradually up, finding the anterior ethmoid and identifying the skull base before you finish the anterior ethmoidectomy. Once that is over, we then turn our attention to the posterior ethmoid. You enter the posterior ethmoid by perforating the basal lamella, usually in an inferomedial point. This is now safe. If you go too high, you're likely to hit the skull base. If you go laterally, you might hit the orbit, and if you go medially, you might get into the cribriform area. So this is a good area to stay inferiorly, and stay medially is generally a good area to enter into the posterior ethmoid. You must clear the posterior ethmoids until you reach the skull base superiorly, the orbital apex laterally, and the anterior wall of the sphenoid posteriorly. What you must remember is that the posterior most wall of the posterior ethmoid usually lies posterior or behind the anterior wall of the sphenoid, especially in its lateral aspect. So it's not necessary that if you continue going behind and following the posterior ethmoid, especially in a superior lateral direction, that you'll enter the sphenoid. In fact, you will then enter the intracranial cavity. So it's important then to turn your direction once you have identified the skull base and the posterior part of the ethmoid, to turn your direction inferomedially if you want to get into the sphenoid. Again, remember that you're going to be working very close to the orbital apex and the optic nerves, especially if you have an ONOD cell situation. So you must have studied that on the scan preoperatively and have it in mind before you go into surgery. So to continue with the same patient, you have identified the ground lamella. You are seeing the lamina papyraceae laterally, the inferior-most part of the ground lamella, which you want to save, because this adds stability to the middle turbinate. And going just above that, but staying inferomedially, you want to perforate so as to enter the ground lamella. Enter into the posterior ethmoids. Having done that, we then put a straight ethmoid forceps and open it inside and rotate it so as to have your bones angled in such a manner that it makes its removal easier. We can then enter into the posterior ethmoid, and knowing from the scan remove the posterior ethmoid cells. In these couple of videos, we've intentionally not used the debrider to show you that it's possible, even with a forceps, if you're gentle, to remove all the cells in an atraumatic fashion. In fact, sometimes the polyps aid in removal, as you saw in this situation, that one polyp helped in opening up the other cells, and we managed to get 3 cells opened up here under the orbital lamina papyracea. And this then would then complete at the orbital apex here the posterior ethmoidectomy and expose the anterior wall of the sphenoid. Medially, you should see the anterior edge of the superior turbinate, again confirming that you're now working in the posterior ethmoids and not in the anterior ethmoids. So let's look at another clip of an ethmoidectomy, and this is again from the same patient you remember from our CD2 and from the frontal sinus surgery. We are finishing off, having finished the anterior ethmoid visualization and the frontal recess. There's a small cell in the suprabular area which we need to identify and clear, and you can see how this bone looks different, much thinner and a little pinker as compared to the skull base, which is just behind it. And that bone there, and now you can see it identified here as well, is a little more yellow, and it feels a lot thicker and stronger as compared to the thin partitions of bone between the cells, even in the suprabular area. So having identified the skull base at any one spot, it is then easier to follow it posteriorly or anteriorly after having removed the rest of the ethmoid cells here. And you have to remember also that the skull base slopes from anterior to posterior in an inferior direction. So your surgery will always be inferiorly, and as you can see here, we're now opening into the posterior ethmoid cell, that large posterior ethmoid onode cell, which you can see on the CT scan here, as well as on the sagittal cut. You can see a very large posterior ethmoid cell which has an onode-like configuration. And to open into that cell, I have gone inferiorly instead of going upwards. I have my skull base identified in the anterior aspect, so having opened it up, then I can already look inside and see the optic nerve, confirming that I'm now in the onode cell, and that's the optic nerve I would see here. I can then remove this bone, superior bone, so that I'm level with the skull base in the anterior aspect. And now I have a visual landmark of the skull base. So I know how much of the skull base to remove anteriorly. And so using a debrider or a punch, I can then remove any ledge of bone, not removing any flat bone, till I have identified skull base all the way through. So now when we look into this posterior ethmoid cell, we can see the skull base here as well. You can see the entire optic nerve, and if you look carefully, you can even see pulsations of the internal carotid artery. In those situations where you have an onode cell, just to show you a couple of figures, you see this is the ethmoid, and you have another important landmark is the orbital apex. Your orbital apex, your sphenoid sinus will always be infero-medial to the orbital apex, so try and find your orbital apex here and know how it would continue into the optic nerve. Another important landmark is the maxillary sinus ostium. If we draw a line, a maxillary line from the superior aspect of the maxillary ostium backwards in a straight line, then what lies above this line usually is the ethmoid sinuses, whereas the sphenoid will usually come below this line, extending posteriorly from the superior aspect of the maxillary sinus. So here we have opened into the onode cell, you can see the optic nerve, and this then would represent the anterior wall of the sphenoid sinus. And in the next cut, in the same patient, we have opened up this wall to show the relationship of the posterior ethmoid with the onode cell and that of the sphenoid. So here you have the orbital apex leading into the optic nerve, and infero-medially the entire sphenoid sinus, and below which will come the internal carotid artery. So this ends our CD3 up to dissection of the ethmoid, and in our next CD now we will take you into the sphenoid sinus. Thank you.